Okay, so as usual, I won't do the full lecture. It's already on the recorded lecture on Canvas. Now, let me just explain. When we say head injuries, and if we compare this to hemorrhagic stroke, the management is really the same. So what were the causes of hemorrhagic stroke again? There were three identified: severe uncontrolled hypertension, AVM, arteriovenous malformation, and aneurysms, right? Okay, so those were three. And then those three will of course cause bleeding inside, correct? So it doesn't really matter whether it was caused by a ruptured aneurysm or ruptured AVM or ruptured arteries because of severe uncontrolled hypertension. Take note that hemorrhagic stroke can also be precipitated by stimulants, let's say recreational drugs. Let's say Miss ZB decides to snort really thick lines of Coke, for instance. Okay. And then, it's her first time. She didn't know. Okay. So she took the whole thing, and then that causes her blood pressure to shoot up to over 250, for instance. That can be enough to cause a ruptured artery. Okay, so the blood pressure shoots up, so that can lead to a stroke. So there's really no difference from a head injury. Head injury can either be caused by penetrating or blunt force trauma. So either caused by bleeding from a hemorrhagic stroke or bleeding from a head injury, the management will be the same. Plus, the resulting increased ICP is exactly the same as well. So the patient's presentations will be very, very similar because they're all manifestations of what? Increased intracranial pressure, right? And increased ICP was already mentioned on the section under ischemic stroke. So there's really no difference, okay? So there are earliest manifestation, of course, is in the level of consciousness. This section just mentioned about prevention because this one is under head injury. Of course, we'd like to assume all head injuries are preventable, but obviously not from violence, for instance. Okay, or yeah, so there are accidents, but we try our best. Let's say helmets, for instance, or the use of seat belts, right? Not drinking and driving, and all of that. So these are all mentioned around here. Now, contrary to popular belief, wherein we think it's teenagers that suffer the most head injuries, it's actually the elderly. Okay, both from at home, from a fall, for instance, or even car accidents. Car accidents, the higher number according to IIHS is actually among the elderly. So whether it's hemorrhagic stroke or head injury from brain trauma, for instance, there are two sets of problems here. So first is the primary injury. The primary injury is the direct result of either the hemorrhagic stroke or the head trauma, whether you were shot in the head, stabbed with a knife, or hit with a baseball bat, for instance. So there is some actual laceration, bruising, bleeding, injury to the brain tissue itself. However, aside from that, over the next 24 to 48 hours, the patient's problems will actually get worse because of the skull. The skull is the most rigid compartment in the body. Now, we already discussed the concept of the Monroe-Kelly doctrine. You remember that doctrine? No. What does that say? If volume in one component increases, then volume in another component must be displaced, correct? So we did that in the glass of water. Remember when I compared the glass of water, it's already full, right? So just like the skull, you already have brain tissue, 80%, 10% CSF, 10% blood, correct? That's 100%. So if you increase the volume by adding one more drop to that glass of water, which was already topped, what will happen? Something will spill. So that explains the Monroe-Kelly doctrine. You can only put 100% inside the skull. So any increase must result in a displacement. Something else has to go. So if you increase brain tissue, for instance, because of swelling, edema, or increase blood volume by causing a hematoma, a bleeding, or if you obstruct CSF drainage by causing shifts, herniation of the brain, or compression of the natural drainage pathways of the CSF, you increase CSF volume. So the Monro-Kelly doctrine states what? If volume in any of those three components increase, then naturally volume in another component must be displaced. Something has to go, right? Because there's only room for 100%. There is no room for 101 or more. Okay. And then based on the anatomy and physiology, which is the only natural opening of the skull, the foramen magnum. And we can't displace the spinal cord. The spinal cord is already displaced. Okay, it's already coming out. So the only thing we can displace is the brainstem. Right, so that's why the brainstem is the closest one to the opening. That is the first thing that will be pushed out. Any increase of the other three components. Does that make sense? Okay, so it doesn't really matter whether the increased ICP was caused by hemorrhage from a stroke, or hemorrhage from a head injury, or swelling of the brain tissue from head injury, or again, in the case of CSF is supposed to be like a river, constantly produce and constantly drain. Now, if you cause any swelling, any bleeding, hematoma, it will obstruct the natural flow of the CSF. So as a result, CSF volume will also increase, increasing ICP. So let's talk about the secondary injuries. Now, there are up to 6 secondary injuries that will result after the initial injury. So for instance, I hit Miss Claude, Miss Morley, I hit her because I asked her out. She said, hell no, okay? Hell no, you old, and then she could have just said no, but then she said other things to me. So my ego was hurt, and then, I just lost it. So I hit her with a baseball bat. And then now, this is what happened to her now. Okay, so she had increased ICP because of the bleeding. Okay, I didn't crack her skull though. Okay, I thought I hit her hard enough, but no, her skull remained intact. But I did cause swelling and bleeding. So over the next 24 to 48 hours, this is what's going to happen to her. She's going to develop intracranial hemorrhage, which of course will cause increase in intracranial pressure, correct? She'll have edema, intracranial hypertension, hyperemia, seizures, vasospasm. And as a result of these, she will have hypotension, hyperthermia, etc. Now, the cause of the hypotension, hyperthermia, hypoxia, hypercarbia, infection, and of course, decreased level of consciousness is the brain herniation. Because what is the function of the brainstem? All your vital functions. Okay, so that's why the CO2 levels rise, because what happens to respiratory rate? Decreases. Heart rate decreases. Okay, everything decreases. Right? Monro-Kelly doctrine is explained there, so I won't repeat that. So there are many forms of head injury. We have scalp injuries, skull fractures. Now, the Monro-Kelly doctrine, by the way, only applies in a closed head injury. If, let's say, Elise was riding a motorcycle without a helmet, and then she suffers a accident on the highway, and her skull is open. Now pieces of her brain are on the asphalt or on the first responder's shoe, for instance. They stepped on it, they didn't know what it was. So does the Monro-Kelly doctrine still apply? No. Okay, so only in a closed head injury. Yes, ma'am. 2056. Yeah, somewhere. 2056. Okay. Manifestations again are all suggestive of increased ICP, along with, of course, if there are fractures, then you'll see some CSF leak coming out of the ear, coming out of your nose. And how do we know it's CSF again? Halo sign, okay. Let's go to management now. So head injuries are managed in the same way as hemorrhagic stroke.
What are the serration and deceleration heading before surgery?
Oh, that's just the mechanism of injury, but they result in the same thing. So they will result in coup or coup contra coup injuries, meaning the uh, acceleration most likely will cause posterior injury, whereas if you have acceleration deceleration, then it'll be both. Okay, so your skull will I mean your brain will hit the front of the skull and then ricochet toward the back. Now you have coup contra coup. Okay? It's just the mechanism of how you sustained it. Yeah, coup like coup d'etat, COUP. A few things here, just the difference of in the terms. Contusion is actual bruising, injury to the brain. That could be laceration, like the example Mr. Boado was asking, acceleration, deceleration force. Okay, that can result in contusions. A concussion is different. Concussion is jarring of the brain. However, concussion is a form of mild TBI already. That's mild traumatic brain injury. And as already mentioned, increased ICP sets in, and the patient's problems over the next 24 to 48 hours are going to get worse, okay, as there is now swelling, well, with brain injury in general. Okay?
Question. Why do they always say, when someone has a concussion that they shouldn't sleep?
Um, they don't want the patient to, because chances are if you sleep, you may not be able to wake up because of the secondary injuries that will set in, because now you have hydrocephalus, and then you could have seizures, for instance. So you have a better chance of um, keeping your faculties if the patient stays awake. Okay. Now, as far as hemorrhage, well, of course, once blood comes out of the blood vessel, it doesn't stay wet, correct? It becomes a hematoma now, right? Now, since there are many layers in the skull and the meninges, regardless really of where the hematoma forms, they become space occupying lesions. The only exception is, of course, if it's a scalp injury, then it has nothing to do with increased ICP because it's outside the skull. Okay, so the hematomas we're talking about here are either epidural, subdural, subarachnoid, or intracranial hematomas, okay, or intracerebral hematomas. So this is what I mean by when you have injuries like this. Look at the ventricles now. So these are your ventricles in the brain. Ventricles just like your heart. These are chambers. CSF are stored there, and these curvatures in your brain are the natural drainage pathways of the CSF. Now, if you have hematomas like this, now you're disrupting those, you're compressing those natural drainage pathways. So now you have hydrocephalus at the same time, not to mention the space occupying hematomas. So now you have increased ICP, your brainstem definitely will be displaced, okay, as a result. It will be brainstem herniation. The difference here is just how soon will the patient die. Okay, so for instance, subdural hematomas are very uh, what's the term for your okay, I forgot the term. So I'll just describe it. Um, the closest thing is tricky, right? Meaning the patient will have absolutely no symptoms initially at the time of the injury. However, the patient's demise is slowly occurring in the background. So when the patient finally has manifestations, it's already too late. Okay, so this is particularly true for the elderly. Let's say you have a nursing home patient, right? They fell, and then it's right at shift change, right at the time where you don't want any falls, right? So what are you gonna do? You have an appointment you can't afford to miss. Okay, but it happened at your shift. It's still within your time. It's 6:45. Shift change isn't until 7:30. You know what you have to do. You still have to report to the doctor, and doctor will always send this patient to the hospital. It's a lot of paperwork. Now you have to call 911. Now you have to call report to the give report to the EMT, and then send all this paperwork with the EMT to the hospital. All right. And that's not gonna happen in 45 minutes. This is a lot of things to do. Okay. So tendency is the patient also has the same interests. They know that without any visible injury, they're gonna sit in the ER for 8 to 12 hours. They don't want to go either. So they'll say, I swear I never hit my head, even though they did. And especially if this patient is on Eliquis, aspirin, clopidogrel, all right, you can guarantee there's some bleeding there. Okay, the slightest, trauma, yeah, there's already some bleeding there, but it doesn't show right away. It doesn't show until maybe 24, 48 hours later. Again, at which time the increased ICP will go like this. Okay, and then what if it happens during their sleep? So this is another reason why, let's say you guys, you've seen it in movies, don't let them fall asleep, right? That's another reason. Okay. So let's say the increased ICP happens in their sleep because they know they're tired. It's time to sleep, and then all the while it's bleeding inside. Okay, and then now they won't wake up. Hey, why is this patient not waking up? Okay, oh, they fell 2 days ago. No, 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 no. She should have been checked out at the time of the injury. We should have seen it happen already. Okay. So I'm just warning you, if you end up in a long-term care facility, okay, so let's say that's what you like, and then this happens, because these people will do that. All right. Then you have the same interest. You don't want to send the patient to the hospital because you have no time. Patient doesn't want to go either. All right. So just FYI. As far as chronic SDH, all we do here is to monitor it. Every few months, we will do a serial CAT scan just to make sure the hematoma is stable, meaning it's not growing any bigger. It's supposed to either stay the same size or decreasing. Concussion, as I mentioned, this is a mild form of traumatic brain injury. So there is temporary loss of neurologic function here. They do not meet inpatient criteria. So if they are diagnosed with a concussion, which is again mild TBI, the patient is discharged from the hospital. We can't keep them. There's no, we won't get reimbursement. Okay, why did you admit this patient? Right? However, if you read the next statement, on discharge, the patient will be monitored for the following. And if they develop any of these, what is the instruction? Come back to the ER. All right. Why? What's happening to the patient when they show these? Is it still mild?
No.
No. It's become moderate to severe TBI. Moderate to severe TBI, especially severe TBI, those patients do not survive. Okay, the most they'll stay alive is 48 hours. That's it. That's the record. They'll die. They may live, but they're brain dead. Okay. Let's go to management. So of course we need a diagnosis. So CAT scan, MRI. And here are our treatments for increased ICP. We also had the bullets mentioned under ischemic stroke. What were they again? Head of the bed, what? 30 degrees. Temperature should be within normal. Oxygen level should be high. CO2 levels must be okay. What positions are prohibited? Yeah, prone, Trendelenburg, bending. What activities can we cough, sneeze? Should we do constipated? Okay, all right. Okay. And how do we exactly monitor ICP? Okay, intraventricular catheter. There are other ways to do it, but the most commonly used is the IVC. Okay, so they'll drill a hole and then put a catheter into one of the ventricles. All right, so if the patient does have moderate to severe TBI, these are the interventions. Seizures are expected, so they'll be placed on anticonvulsants prophylactically. When they do have a seizure, then of course we stop the seizure with benzos. When I say benzos, what are we talking about? Diazepam or lorazepam. Okay. If needed, let's say the patient is really in severe TBI, so we will induce a coma. We will typically use barbiturates, or we can also use propofol to sedate them. Okay. Let's go now to surgical management. I won't discuss brain death. We're not really the ones doing this. It's the physician. There are many ways to declare a patient brain death, but doctors will do that. Oh, by the way, there is a phenomenon we call Cushing's reflex or Cushing's triad in other textbooks. There are three here. What is Cushing's triad? This is evidence that there is increased ICP. Okay, so that's the significance of Cushing's triad. However, it's also a late sign. When you see the Cushing's triad, yes, it will confirm the patient has increased ICP. It also will signal that the patient will be dying soon. Okay, so two things about the Cushing's triad. They are bradycardia. Of course, this is caused by brain herniation, obviously, correct? And then there is increased systolic blood pressure with wide pulse pressure. What is pulse pressure? Difference between the systolic and diastolic pressures. In other textbooks, they separated the wide pulse pressure. So here in this textbook, the author said 1, bradycardia, 2, increased systolic blood pressure, 3, increased or wide pulse pressure. In other textbook, they say bradycardia, number 2, increased systolic blood pressure with wide pulse pressure. And then the third is the Cheyne-Stokes respirations. You know Cheyne-Stokes, right? No, the really irregular, rapid respirations right here. Respirations become rapid and irregular. Okay, so they put that as the third. All right. So I don't know what NCLEX will use as a textbook. What's the purpose again of maintaining normal temperature? What is the effect of fever on ICP? Okay. So here's the rationale there. Okay, so not good for the brain. Please take note of your pupillary changes right here. Please read that on your own. And remember diabetes insipidus and SIADH. Okay, so what were the causes of DI and SIADH? Brain trauma, brain surgery, stroke. Okay, so watch out for those. It can either be diabetes insipidus or SIADH. The patient is fed. Of course, we'll use a feeding tube here, nasogastric feeding tube. And these are your interventions to avoid any injury to the patient. Because remember, the level of consciousness is lethargy at best, comatose in the worst scenario. So we mentioned all of these already. So if the patient has a fever, we do cooling measures, position again 30 degrees. If needed, the patient will be intubated, okay, to maintain proper oxygenation. Because if we can't control the respiratory rate, then we'll have to intubate. Okay. And these are your pressure ulcer prevention. Now let's go to post-op because this patient will have surgery. Well, not everybody, but sometimes the last resort is to perform surgery. Now, purposes of the surgery is either to decrease pressure, meaning decompress the brain, perfuse the brain tissue, or to evacuate the hematoma. Let's say the hematoma is too big, then we have to get rid of it. And also to stop acute bleeding. In the case of hemorrhagic stroke, if it's a bleeding aneurysm, we have to stop it, so surgery. There are 5 medications that you need to, I can't see where it is, but let me just tell you the 5 medications. 1, PPI. Why PPI?
Yes.
Okay, to prevent stress ulcers. Second, if you had surgery, that mean there's swelling of the brain? Yeah. Will there be increased ICP? Will there be seizures? So what are we giving? Anti-seizures. Okay. I mentioned there is swelling and edema. What can help reduce that? Diuretics. Okay. How else can we reduce it? What can be given to reduce inflammation? Steroids. Okay. The steroid use is dexamethasone. Okay. We don't use methylprednisolone or prednisone. We use what? Dexamethasone. Brand name Decadron. Okay. So that's number 4. Number 5 is antibiotics. Okay. Because you had surgery, so of course you'll be given antibiotics. So what are those 5 drugs again? PPI, anti-seizure, diuretics. Oh, the diuretic, sorry. The diuretic given is only mannitol. Okay. Mannitol only. Sometimes they'll supplement it with loops, but the main diuretic use is mannitol. What is mannitol? It's an osmotic diuretic. Very good. So it reduces cerebral edema by removing water. Okay. It's a diuretic though, so therefore, what should your assessment be before safely giving it? Any diuretic will do what to the blood pressure? Okay, remember, we already talked about CPP, right? What is our CPP? It must be 70 to 100. So therefore, if the blood pressure is too low, is it a good idea to give mannitol? Okay, so if that's the case, then the patient will be given hypertonic saline instead.
Oh,
All right, that's an option. Meaning we need to decrease cerebral edema. We cannot give mannitol. The blood pressure is like so-so. Okay, because remember, blood pressure has to be 140/90 or better, right? So in order to maintain a CPP of 70 to 100. So therefore, if blood pressure is too low, then we'll have to, okay, instead of a diuretic, instead of mannitol, we'll give hypertonic saline. Sorry? Yeah, the example is 3% NaCl. Okay, spinal cord injury now. The mechanism of how you sustain this is exactly the same with brain trauma. In fact, we assume both are present. So if you had head injury, we assume you may have spinal cord injury as well. Okay, until we rule it out. Of course, we'll test you for both, but we assume until we get a CAT scan or MRI that you also sustain spinal cord injury, okay? And vice versa. So head injury, meaning we suspect spinal cord injury. That's why we always put what? A cervical collar, okay? To stabilize the spine. A few terms, paraplegia. What does that mean?
when you're paralyzed.
Okay, paralyzed. Okay, lower half. Now, there are different levels though, depending on whether it's cervical, thoracic, lumbar, etc. Tetraplegia, also called quadriplegia, is
Whole body.
paralyzed from the neck down. Okay. Again, there are different levels. So speaking of which, the testable part is, okay, I won't test you on 63-7. Test you on table 63-3. Okay. So the question will be, I'll give you either the level. So I'll say, let's say, oh, patient suffered a T3 fracture. Okay, so it's T3 spinal cord injury. The nurse expects this patient to be able to do which of the following? Could be multiple choice, or it could be select all that apply. Okay. So what can T3 fracture SCI patient do? Can they use a motorized wheelchair?
Yes.
Yes, because they have full hand and finger control. Okay. Which patient will be dependent on a ventilator?
And about C4. C4 and above.
So C4, do they need to be intubated or tracheostomy? No, because they have diaphragm movement. So they can breathe without a ventilator. Okay. So C3 and up, mechanical ventilation.
Oh, I see it.
Can a C4, since they have good head and neck sensation and some shoulder elevation, good head and neck sensation and motor control, so can they use a wheelchair?
No. We are shoulder movement.
Fifth column says they can.
Control all electrical.
This is 2025. We have other means to control a wheelchair without using your finger. Remember Christopher Reeve?
Oh, yeah.
He had an electric wheelchair. He did not need anyone to push him around. He controlled it with his mouth.
What? Yeah.
Yeah, you can just blow into a straw.
And
Right? So again, this is 2025. You need to be aware there are electric wheelchairs that can do that now.
Oh,
Okay?
but it says shoulder control.
Again, head, chin, you see, voice, mouth, chin, or shoulder controlled electric wheelchairs. We have so many ways to activate it now. Are we clear?
Yeah.
Okay, so expand your knowledge, okay? So don't think of wheelchairs as those you see, like this or like this. Okay, we have mouth now, all right? Okay. So get an idea? Okay, so I'll probably give you 2 questions on that, on here. Maybe 3. This is the 3rd exam. Yeah, I'll give you maybe 3. That way it's worth it. Okay, you study this. Okay, I get 6 points. Yes.
Says like independent elimination, does that mean that they can feel it?
Correct. Yeah. And then they can meaning they're not incontinent.
Yeah.
I know, sorry.
For what?
Which one are you talking about?
Think from C7 below, it says independent, so they can feel.
C7.
Where it says independent?
Yeah.
Yes, that's what it means. Yeah.
So that means he can feel it, you said.
Mm-hmm.
So, for.
But it's a different thing though with because here, although they can do wrist extension, so I guess, and they have shoulder. No, I don't think they can transfer. Yeah, they can dress and eat, but look at mobility. With C6, yeah, that's all they can do. They can, well, if they can transfer in and out of a wheelchair, then they can transfer on the toilet. So yes, I guess there.
I think she's more asking, like, are they able to sense that
Yeah.
using that?
Feel it.
Yeah.
Oh,
They can feel it.
they're continent.
They probably can't control
Oh,
fully. But yeah, there will be some sensation to go.
In this chart, then it means they can. Also.
Yeah. So here, when it says dependent, then I guess they're incontinent.
with C5, is it maximum wisdom, would you consider that dependent?
For which one?
C5.
Elimination? Okay, maximum assistance, meaning when we say dependent, they totally have no control over anything. With maximum assistance, yeah, they can help some. But yeah, they'll need yeah, probably to at least 2 people. Okay, yeah. Okay, let's go to management of SCI. So after the patient sustains injury, of course, you have to do ABC. That's always the case, regardless of the injury. The drugs, take note that the steroids are no longer standard. Okay, so basically, depends on the hospital, right? Whether they want to do steroid, to give steroids or not. Respiratory therapy, depending again on the level. So if it's high cervical, then the patient needs to be intubated and put on a ventilator. Traction. So what we're testing here is the Halo brace, okay? Halo device. You have a picture and you have a whole, there's a chart here. There's a chart for, I think it's toward the end of the, right here. Chart 63-8, there's a whole chart for the Halo base, okay? So, I mean, Halo brace. So this is the care, what to do if it's something's itchy, all right? In an emergency, pin site care, because there are screws here. This brace is literally screwed into the skull, So it's basically a external fixator device as opposed to the arm or the leg. This one is for your spine. So to anchor it, it is screwed into your skull. So depends. So it could be a few weeks to a few months, depending on how soon the fracture heals. Until then, you'll be wearing this 24 hours a day. Now, there are emergencies. Let's say the patient suffers cardiac arrest, then there is a wrench in the back. So you just take the wrench and then we'll have to take the whole thing off, okay? Because you can't do chest compressions over the vest.
Now pose another problem.
I mean, we have to do priority. The priority now is chest, circulation. So we'll have to take it off. We'll deal with the consequences if we break the neck in the process. I mean, that's up to the patient now. They're gonna have to be, signing life sustaining, treatment. Yeah, to specify what do you want. I mentioned pin site care, right? I mentioned pin site care, it's either peroxide or just saline, to rinse the area. And then some doctors, especially I had neurosurgeons before, they asked us to put betadine ointment around the sites.
Betadine ointment.
Yeah, there's a betadine ointment. But not all. Some just ask us to just wrap it with the gauze. That's it. Depends on the doctor. We know neurogenic shock. We did that in module 1. Let's talk about spinal shock. Spinal shock is a temporary loss of sensory motor function. How do we know whether it's temporary, which is spinal shock, versus permanent para or tetraplegia? We don't know. Of course, if the spinal cord is severed, we know it's permanent. But as long as the spinal cord is intact, there's a chance that it could be spinal shock only. Have you seen season 3 of Cobra Kai? When Miguel fell on the stairs in the cafeteria fight? You don't know what I'm talking about? Then that's the best example I could give. So he was paralyzed for like 3 to 6 months, I think. Then he regained his function. Okay, so it was spinal shock only. So spinal shock is not a true emergency. Okay, so which one's the true emergency? Neurogenic shock. BTE we'll discuss on our next half, okay, under PE. I do have a question. I think it's on the blueprint about sexual activity. Okay. Know that they can still achieve an erection. Okay. Through reflex though. There is reflex erection. Remember Lieutenant Dan in Forrest Gump? Yeah, he had prostitutes, right? Yeah, so they can still achieve an erection, but not at will. It's gonna have to be a reflex. Okay, like stroking the penis, for instance, may produce an erection. Okay, after several minutes, through reflex only. Same thing with ejaculation. So it's not gonna be predictable. And there's a chance they could urinate. Okay, while yes, it's possible. Because again, they have no full control. All right, so we always talk about emergencies. That's why we did neurogenic shock. This one, there's another emergency. So Brandon Sharp next week, your patient, developed autonomic dysreflection. Now, this does not happen during the acute episode, meaning during the first 24, 48 hours, this will never happen. This will happen like days to weeks, forever. So after the acute episode resolves, this is what could happen. Okay, so usually this will only happen to people who have no bladder or sphincter control, which is above T6. So T5 and up paraplegics are at risk for autonomic dysreflection. If it's any lower, then they're not. Okay, again, only above T6. Okay, so T5 and up paraplegics or tetraplegics are at risk for autonomic dysreflection. So what is it? Another term is autonomic dysreflexia or hyperreflexia, acute life-threatening emergency. So can this be on the NCLEX?
Yeah.
Yes, because it's life-threatening. All right, so what is it? Again, when does this occur?
After.
Okay, after the acute episode. Never occurs during the acute episode. So this will be several days to the rest of this patient's life. If they suffered what again? T5 or higher, okay? So above T6. So what caused this? Well, this is characterized by severe pounding headache. So basically, there is sympathetic stimulation above the level of injury, and then you've got parasympathetic below. Okay, I repeat, sympathetic response above, parasympathetic response below, meaning the sensation and impulses are still being sent to the brain. However, there is no appropriate corresponding response. Okay, so there's an imbalance here because of the injury. Now, the trigger for this, so basically it's a severe sympathetic exaggerated response, right? Because there is severe hypertension. The blood pressure will be over 200. So there's, again, sympathetic. Therefore, you have diaphoresis. Okay, so all the sympathetic are above the level of injury. Okay, so above the hips, basically, up here. But then none below. So you'll see sweating, goosebumps, okay, flushing, all above, but nothing below the level of injury. Okay. So what triggers it? Usually the two most common triggers are distension of the visceral organs, particularly of the bladder or the bowel. Think about it. These patients are paraplegics, correct?
Correct.
So can they urinate at will?
No.
They have to self-cath, all right? They have to self-cath in order to empty their bowel. They have to have a GI cocktail, a bowel regimen, in order to have a bowel movement. Sometimes they may need, if they're already constipated, they may need manual disimpaction, okay? But without a catheter or without a regular bowel regimen, these patients will not be able to empty their bladder or empty their bowels, okay? Now, can they feel if they're sitting on their testicles? No, there's no sensation. This is above T6. Can they feel if they already have a pressure injury down there? No. So the triggers, the stimuli are, again, full bladder or full bowel, or any pain. Here, stimulation of the skin, tactile pain, thermal stimuli, pressure injury. Anything painful, basically. Okay. A full bladder, is that painful?
The pressure.
Yes, it is painful,
Pressure.
right? Yeah. I don't know what constipation feels like. Never had that. But I heard from my sisters that's uncomfortable. Okay, discomfort, not pain, but uncomfortable. So these are negative sensations, correct?
Yeah.
So will they trigger sympathetic stimulation? Yes. The patient doesn't feel it. So even though the patient doesn't feel it because there is no sensation, correct? Doesn't mean the stimuli are not firing up to the brain. So that's what triggers the response. Okay. Okay, so there's an exaggerated sympathetic response. What do we do? What's the first step?
Sit them up. No,
Well, yeah, that would be applicable because they're either laying down or already sitting down, right? So
Cause if they're.
sit them down would be inappropriate because they're not standing. Yeah, okay, so
Sit them up.
yeah, so place the patient in a sitting position. And then what's the next intervention?
Bladder,
What were those two most common triggers again?
bladder,
A full bladder or a full bowel? You're lucky if it's the bladder. If it's the bowel,
So you're straight back, what's that?
if it's the bowel,
Oh. Enema.
yep, double glove. No, not an animal. Double glove, you have to disimpact. All right, so please follow the interventions. These will be what you're expected to do to Mr. Brandon Sharp next week.
Why? You don't have a bowel impact.
I don't know.
it's sick.
And once this patient survives, okay, so let's say they didn't die from autonomic dysreflexia, you saved them. What is now your mission? Make sure you have it in their chart history that they had autonomic dysreflexia. So moving forward, they should have a regular, catheterization and daily, no, not, daily assessment of the, meaning they should have a bowel movement at least every day. Correct. Any question? All right.